Yes. Hi, everybody, and welcome. I'm Zahir Soonawalla. Most of you will know me. I'm one of the surgeons at Oxford. I'm a hepatobiliary surgeon, and it's one of the areas where minimally invasive surgery has come in a modest way, and with certain problems and controversies, which I wanted to share with you. So the topic for today is focused on minimally invasive pancreatic surgery. So it's always useful to look at the history of how the service developed and what the evolution and progress has been, because that's often quite educational and makes you aware of the problems and issues that people faced. With the types of pancreatic surgery, enucleation is probably the first one that was done laparoscopically for things like small neuroendocrine tumors, most often insulinomas. But it's mainly distal pancreatectomy and pancreatic head resections that form the bulk of pancreatic surgery. And that's where the main focus of the discussion will be. There's a smaller group of other pancreatic operations, total pancreatectomy, central pancreatectomy, and of course, surgery for pancreatic necrosis that we will not be covering today. So it's important to know the outcomes, to know the challenges particularly, be aware of what the current status is, what the trends are, particularly what the situation is likely to be in 5-10 years' time, and how that should affect your training. So you can't really talk about minimally invasive pancreatic surgery without bringing this chap up. He's one of the pioneers of laparoscopic surgery, Michel Gagne. He's done more or less the first laparoscopic distal pancreatectomy, the first Whipple's, the first, I think, lapadrenalectomy, the first duodenal switch lap procedure for morbid obesity. He's been an absolute pioneer in this field. And when you look back, that he did his first laparoscopic Whipple's in 1993, when we were still trying to progress with more difficult lap choles, and all we could do were the straightforward lap choles. It's pretty impressive. But pancreatic surgery didn't make much progress in the 1990s. There were only a small number of cases. And even the biggest series in 2002 was only of 20 cases. So it's really been in the last 15 years where it's taken off in a big way. There have been a lot of large series of laparoscopic distal pancreatectomies, and people typically started with benign pathology, small tumors, neuroendocrine tumors. There was controversy about whether it should be used for adenocarcinomas, and that controversy persists. And we'll discuss that in a bit more detail. But all those case series showed that it's relatively safe. The conversion rates are relatively low. Blood loss in most of the series is actually less than with open surgery. So that's pretty impressive. One thing that did raise a bit of concern earlier on is that when you look at historical numbers of distal pancreatectomies, many were not distal pancreatectomy with splenectomy, but a lot of them were with splenic preservation. And the recommendation is that for benign tumors like a mucinous cystadenoma, or for neuroendocrine tumors that are less than 2.5 centimeters, where the chance of lymph nodes being positive is low, you should try and preserve the spleen. And when you look back at the laparoscopic distal pancreatectomy series, the incidence of splenectomy was in the region of 85 to 90%, which is higher than the corresponding open series. And the belief is that because it's more difficult to preserve the spleen and difficult to take the spleen, the pancreas off the splenic artery and vein with multiple short, small branches, people sort of divided the splenic vessels and lopped off the spleen with the pancreas just because it was technically easier to do. And that's, again, one of the challenges. And that's one area where the robot has proved to be superior to the laparoscopic approach. Now, this is a series looking at the UK experience of 11 HPB units. And as you can see, the case selection, the most common pathologies are neuroendocrine tumors and mucinous cystadenomas. People are still a bit conservative with pancreatic ductal adenocarcinoma, but it's getting more common now to do that minimally invasive as well. The mean duration of surgery was 4 hours, which is about the same as open. Blood loss was quite respectable. Conversion to open surgery in that series was 12%. Most people stapled the pancreas, which is the case also with open surgery. The pancreatic fistula rate was about 15%. Are you all aware of the change in definition of pancreatic fistula in the last few years? Omer, Mohan, Megan?
I'm not sure about the change actually.
No. So the original, there was an international study group that classified pancreatic leaks into grade A, B, and C. And A were the biochemical leaks, where you have high amylase, but no consequence for the patient. And the drain dries up and it's taken out before the patient goes home. So day 3 amylase of over 3 times upper limit of normal was taken as the definition of a pancreatic leak. Grade B is where there is some clinical consequence. It delays their recovery. They need antibiotics. They might need a percutaneous drain. Grade C is where it results in ICU admission or reoperation, organ failure, complications like secondary hemorrhage. B and C somewhat match Clavien-Dindo B and C. In the more recent definition, the same group revised it and removed grade A. So grade A pancreatic leaks are no longer called pancreatic leaks. So our incidence of leaks has nearly halved, which is very good, because that number of 15% would probably be closer to 25% to 30% if you included the grade A's. Yep. So now there's no such thing as a grade A pancreatic leak. There have been 2 randomized trials. One was a small single-center trial, and the other a large multi-center trial done by the Dutch group. The Dutch group, the HPB group, are really phenomenal at carrying out randomized trials, and they seem to come out with 1 or 2 such trials every year. This was a proper blinded multi-center randomized trial compared to the LAPOP, which was a single center non-blinded trial. And it showed reduced hospital stay, reduced time to functional recovery, a reasonable conversion rate of 8%, less blood loss in the laparoscopic group, longer operative time, slight trend to a higher fistula rate, and slight overall cost reduction, but not significant. And overall, it just confirmed what all the large case series had said and what people expected, that there is a learning curve, but laparoscopic surgery is here to stay for distal pancreatectomy. The one area where it remains a bit controversial is with cancers. And there are two reasons mainly for that. One is the question of, can you actually get an equal R0 rate? Can you resect as radically? And the second is, do you get the same lymph node yield? It's useful when doing pancreatic surgery to be aware of the various lymph node groups. So with distal pancreatectomy, the lymph nodes at the splenic hilum and the ones along the splenic artery. Can you see my pointer, by the way?
Yes, we can.
Yep. They are removed with the spleen, with the spleen and the tail of the pancreas. But for cancers in the body of the pancreas, the 8A station, which is the one sitting on the common hepatic artery, 9 at the top of the celiac, and 16B along the left border of the SMA, also should be removed. And to do that laparoscopically is quite tricky. It's also quite tricky to ensure a good posterior resection margin. And to achieve that, you have to do what's called the RAMS procedure, where you approach from medial to lateral. So rather than mobilizing the spleen and bringing the spleen and tail of pancreas up, which used to be the traditional open way of doing distal pancreatectomy, you approach the neck, find the portal vein SMV, divide the neck of the pancreas, remove these lymph nodes, and go down into the retroperitoneum and go into Gerota's fascia. And excision of Gerota's fascia with the pancreas and excision of the left adrenal gives you a better chance of getting an R0 resection. And that medial to lateral approach with excision of Gerota's fascia is called the RAMS procedure. So there's a diploma trial that started 2 years ago. It got interrupted by COVID. It's still ongoing. And it's a multi-center, blinded, randomized trial of lap versus open, specifically for suspected or proven adenocarcinoma in the distal pancreas. And we are one of the centers taking part. The results are still not out, obviously, but it might help answer these questions. However, at the same time, there's been more and more development with robotic surgery. And people have compared with propensity score matched cohorts the outcomes after laparoscopic and after robotic distal pancreatectomy. And the robotic groups tend to have lower conversion rates and better splenic preservation. But there was one downside in that with the conversions, the converted group tended to have a worse outcome than the converted group in the laparoscopic cohort. And people felt it might be that with robotic surgery, people are either converting a bit too late or conversion takes more time because you have to undock. And it's felt that it's certainly going to be of benefit for adenocarcinomas for doing those complex node dissections. And for people who have used it, they've actually found that they do more and more of their cases robotic and less laparoscopic. And it may be that nearly all distal pancreatectomies 10 years down the line may end up being robotic. So case selection is important. Understanding port positions and approaches are also important. I'll briefly touch on that. With distal pancreatectomies, the tail part of the pancreas and the body and neck are completely different in access. The neck of the pancreas is better approached with the patient supine, and you can not stand between the legs, get good access, open the lesser sac widely, and you can visualize the body of the pancreas, mobilize it, identify the SMV, portal vein, splenic artery, hepatic artery. But that doesn't give you very good exposure to the tail of pancreas and spleen. The tail of pancreas and spleen are better accessed with the patient in the right lateral position with a lot of tilt. Unfortunately, in that position, you have no access to the neck of the pancreas, SMV, and portal vein. So you have to decide very carefully what position you want your patient in and what ports you want to put in. And a lot of the learning curve in laparoscopic surgery is not technical. You can quite quickly learn to dissect well. You can quite quickly learn to be not technically adept at instrument handling, tissue handling, suturing. A lot of the learning curve comes after that with individual procedures. Now, how do you do a lap distal pancreatectomy? What are the ideal cases? Now, how do you adjust port positions depending on the size of the tumor or depending on the patient build? What's the best approach? What are the best instruments to use? And that's the whole second learning curve. And that's specific to each operation. One important lesson from the robotic and the laparoscopic cohorts has been that early planned conversion doesn't seem to affect our outcomes adversely, but late hurried conversions for emergency bleeding or problems has detrimental outcomes. So it's important to be cautious during surgery and plan your conversion quite carefully and at an early stage. The next big hurdle was, of course, pancreaticoduodenectomy. And you'll be aware that whether it's Whipple's or PPPD doesn't really matter. We use the term more or less interchangeably. And after Michel Gagne's first one in 1993, several people tried it, and a few had good success, but not many. And there are a few well-known pioneers: Michel Gagne, Palani Velu in India, Mike Kendrick in New York. And they all got to a stage where they could do the majority of their Whipple's laparoscopic with reasonable operative time and very good clinical outcomes. Unfortunately, not many people could replicate that. It was a pretty complex operation to do laparoscopically. Most of the centers that tried found that they could do a small ampullary tumor in a slim patient, but they couldn't do the majority of their Whipples. There have been several randomized trials. The most important one is the Leopard 2 trial because it was a proper multi-center blinded trial, again done by the Dutch group. and they had to close the laparoscopic arm because of a higher complication rate. So the conclusion was that though laparoscopic Whipples has been successfully carried out at some centers, it's not got a long-term future. It's not here to stay. It can't be adapted widely to the majority of centers and the majority of surgeons and the majority of Whipples. But robotic pancreaticoduodenectomy has been very successful. There are well over 1,000 cases published in the literature already, with very good operative times, conversion rates which are pretty low. The evidence so far suggests that there is reduced hospital stay of about 3 days, better functional recovery, reduced complications, in particular, wound infection and wound complications, and similar mortality. So the trend nowadays suggests that distal pancreatectomy will be a combination of laparoscopic and robotic. Whipples, laparoscopic will more or less disappear from the scene, whilst robotic pancreatic surgery will become more prevalent, and Whipples will largely be a combination of robotic and open. But the key message, I think, is that HPB surgeons, and probably all GI surgeons, will need to be familiar with open laparoscopic and robotic surgery, because I think all centers will have to offer a full package of these procedures. Any questions so far before I move on to, I just wanted to touch on training requirements and learning curve and answer any questions you have before that. And then we can.
Can I just ask, about the pancreatic fistula? Is
Yeah.
the volume a criteria?
Sorry, what is that?
Is the volume in the pancreatic fistula a factor?
No. So the volume doesn't figure.
Okay.
In the definition.
It's just the amylase.
So, yeah, so it was only the level of amylase in the drain. But that's a good point, isn't it? Because
Sometimes you don't know when to take out.
if you've got 5 mils in the drain and high amylase, it's quite different if you've got 100 mils in the drain and high amylase. But that doesn't figure in the definition at all. Sorry, for some reason, I can't hear you properly.
Just saying that sometimes the volume is low, but the amylase is high.
Absolutely. That often happens, actually. And that used to happen a lot with the grade A fistulas.
Right.
The drain's nearly dry. There's only 10 mils in the drain.
Yeah.
On day 3, your amylase is high. The patient's completely well. And by day 7 or 8, the amylase comes down to normal, but you had to label it as one of your pancreatic leaks.
Right.
And that was the problem with that definition of grade A biochemical leak. Right. And that's been removed now from the definition.
Okay. I was just asking about the robotic distal pancreatectomy. You said they had more complications and when they were converted.
So the conversion rate was lower, but when they looked at the outcomes, the lap distal pancreatectomy group, this is of course not trials, this is large cohort series that they've tried to propensity score match.
Oh, right, yeah. Okay.
In the laparoscopic group, more of the conversions were planned early conversions. Okay. And more of the conversions were not done due to a serious event in theater.
Oh, right. Okay.
Whereas many of the robotic conversions were a bit later on due to bleeding, due to a problem.
Right.
And
That's why
the
they were
blood
worse.
transfusion rate, the complication rate, the patient's recovery, and even mortality after conversion was higher in the robotic group, in that small subgroup.
Okay.
So the overall mortality is not higher, but if you have a robotic operation converted, your mortality chance will be higher.
Right.
But your chance of conversion is only about 5%.
Okay.
So it's just a learning point to surgeons who are taking on robotic surgery to be aware of this now finding in the literature. So when you're in a sticky situation, you have to be aware that carrying on causing significant bleeding and then converting does it with it. And if you are stuck, it might be better to have a planned conversion before you have such a problem. Mary, you had a comment?
Will Oxford be trying some robotic?
Sorry, if a drain. So let me just go through the questions. So you said if a drain needs to be placed, then the fistula is grade C. So now I'll just go back to the UK series. So where was the UK? So this is the UK series from 11 centers, and 100% of surgeons kept a drain in. So there have been a few centers across the world that have tried pancreatic surgery without drains, but they're very few and far between. And generally it's quite controversial, but the majority of surgeons leave drains in. Are you talking of if a radiological drain is required, then that automatically makes it a grade C?
Enthusiasm, you were engaged, you didn't doze off halfway through the workout. So that was really cool.
Okay. And your other question was about an insulinoma. Yes, absolutely right. The crucial thing is the distance from the main pancreatic duct. And there isn't a specific distance, but most people would feel that you need about a 3 to 4 millimeter gap to be able to safely find a plane in between where you can apply a harmonic or ligature without damaging the duct. It's difficult to work out on preoperative imaging, so it's more accurate on intraoperative ultrasound. Next question is, would you enucleate an insulinoma in a patient with MEN1, given the risk of multifocal disease? Yes, I would. The aim is with MEN1 that several. I don't know if we have time, but with MEN1, there are lots of challenges with what to do about them. I don't know if I can.
Some days are good, some days are bad.
Let me quickly. Just give me a minute.
I've made it now. I'll keep open mind, but thanks so much.
The brief answer is yes.
This will take another hour in the US. There are 3 appendices now. So one actually, because I heard the 50-year-old. Yeah, exactly. One actually is cancelled. One is cancelled.
I I'm just trying to have a brief presentation on surgery in MEN1. I can't find it at the moment. Anyway, so in MEN1, we may as well chat about it for 10-15 minutes. So MEN1 patients have a lifelong tendency to develop pancreatic neuroendocrine tumors. And that lifelong tendency you can't get rid of. And it's very controversial how aggressive you should be as a surgeon. Insulinomas are generally not that common in MEN1, but you would remove them because living with an insulinoma on medical treatment is not a good quality of life, and long-term outcomes are pretty poor. So with an insulinoma, it's not a challenge. With the gastrinoma, it's more of a challenge. And that's because gastrinomas tend to do quite well with medical management. And most of them are very well preserved medically. That Zollinger-Ellison syndrome you can manage just by escalating doses of PPI. Again, it's quite useful to look at what's happened historically. So if you go back now 50, 60 years ago, most patients with many patients with MEN1 would die in their 30s or 40s, and the main cause of death would be severe bleeding or perforation from peptic ulcers and Zollinger-Ellison syndrome. And the challenge at that time was, how do you prevent that? So people tried partial gastrectomy, vagotomy, it didn't work. They went to total gastrectomy as the solution. It was then realized that there's a tumor in the duodenum or pancreas that's actually producing gastrin. And you need to remove that tumor and that problem is cured. Finding that tumor was hard, and it was occasionally multifocal, and it was more often in the duodenum rather than the pancreas. So around in the 80s, there was an operation designed by a chap called Thompson, where if often they have a gastrinoma syndrome, which is due to a tumor in the duodenal wall, and they have multiple other tumors, which are often non-functioning in the body and tail of the pancreas. So the operation he described was a distal pancreatectomy, enucleation of any neuroendocrine tumors in the head, opening of the duodenum, palpation of the duodenum. Before you open the duodenum, you put a scope down on table and transilluminate the duodenum and look for these small nodules in the wall of the duodenum and enucleate them. And with that, he got a sort of 50 to 60% cure rate of the gastrinoma syndrome. Of course, over years, the cure rate declines because many patients develop recurrent disease. In the late 90s, early 2000s, people started becoming more radical. And they said that the disease often recurs in the gastrinoma triangle, often with recurrent tumors in the duodenum. Why not do a Whipple's? And some people even said, why not do a total pancreatectomy? And the rate of cure of Zollinger-Ellison syndrome was much higher, but the long-term quality of life wasn't particularly great. One of the centers that has the largest MEN1 population is the NIH Bethesda. And they looked at 15-year outcomes following conservative management versus more radical surgery. And there was no difference in survival. And that's because patients with MEN1 neuroendocrine tumors, they often have very long lifespans, even with their tumor. So the aim of surgery is to prevent death from metastatic disease, but there's also a background lifelong incurable condition that makes it more difficult to judge whether being aggressive surgically is the right option. And that's the focus of Omer's question. It's a very important and difficult question to answer. I've probably offered you some insights into the difficulties, but not answered the question. Omer, anything else regarding that you wanted to ask? So the pendulum has swung back a little bit towards conservative management because it was realized that aggressively trying to cure a gastrinoma syndrome in someone who you could just keep on long-term PPI is not necessarily helpful for MEN1. So nowadays, if we can't locate the gastrinoma, 20 years ago, we would have done a Thompson's procedure to try and find it. Now we would just say, carry on PPI, and we'll keep surveying. And if there's a visible growing tumor that's going to have a risk of shortening your lifespan by metastasizing, then it might be worth cutting out. The other thing that used to happen 20 years ago is if someone had 3 or 4 tumors in the pancreas, people would do a total pancreatectomy. Whereas now, if you have a 3-centimeter tumor in the tail and a 5-millimeter tumor in the head and a 5-millimeter tumor in the neck, we would just remove the 3-centimeter tumor with a limited laparoscopic distal pancreatectomy and leave the other ones for long-term surveillance. And now it may take 10, 20 years for those tumors to get large, but that spared the patient 10 or 20 years of diabetes and the poor quality of life from total pancreatectomy. Does that make sense? Yeah, so oncologically, the next question is oncologically, does the spleen need to be excised for a distal pancreatectomy for adenocarcinoma? And the answer is yes. And that's because you want to radically excise Gerota's fascia and all the lymph nodes. So for adenocarcinoma, it's always a radical distal pancreatectomy, splenectomy. For neuroendocrine tumors, there's a bit of a divide because small neuroendocrine tumors are unlikely to have lymph node mets, particularly if they're less than 2 centimeters. And as they increase from 2 to 3, the incidence of lymph node involvement increases. Once they get over 3 centimeters, they have a higher chance of involved nodes. So when they're less than 2, you can do a sort of spleen preserving with no lymphadenectomy. But once they're larger than 2, you have to think quite carefully as to whether you want a lymphadenectomy, and it's better to do a more radical job. With splenic preservation, you have to stay more or less flush with the pancreatic capsule, and you leave nearly all the lymph nodes behind. For pancreatic adenocarcinoma, do you feel there's any role for arterial resection for SMA involvement, for example? Yes, there is. So initially, it was difficult to contemplate surgery for people with what's called locally advanced disease, where there's extensive local vascular involvement. It would need a very big operation with arterial and venous reconstruction. And most patients with pancreatic adenocarcinoma, as you know, have a very poor prognosis. So yes, you could do it, but there's a 70–80% chance that the majority of patients would be dead within 12–18 months. What's made a difference is neoadjuvant chemotherapy. So with neoadjuvant chemotherapy, you can screen out the better prognosis patients. So we use neoadjuvant chemotherapy now for the borderline operable, where there's contact with the SMV portal vein, and the locally advanced group, where there's extensive involvement of the SMV portal vein, or there's arterial involvement. The borderline operable, the majority would come to surgery. The locally advanced, the minority would come to surgery. But when you do pancreatic resection for pancreatic adenocarcinoma, your R1 margin positive rates are in the region of 60 to 80%, pretty high. When you do a pancreatic resection after neoadjuvant chemotherapy, the R1 rates drop to about 20 to 30%. So people are moving more and more towards neoadjuvant chemotherapy, and that's in a way brought radical resections back into the game because you're being more selective. So you're using a PET scan, you're using neoadjuvant chemo, and only operating on the few people who respond well. And you're more likely to be able to do the resection with R0 margins because of the response to chemotherapy. So the artery can be resected from both sides with head resections or with tail resections. With distal pancreatectomy, more than the SMA, it's often the celiac axis. So maybe I might go back to the diagram 1 minute. So going back to the diagram, if you imagine a tumor in the body of the pancreas here, it can easily involve the splenic artery right up to its junction with the hepatic artery and the celiac. And that's a common problem with adenocarcinomas that are very proximally placed in the body, close to the neck. And that can be resected with resection of the entire celiac axis. And the stomach can usually cope with loss of the left gastric as well as the loss of the short gastrics. It's incredibly adaptable. One problem is the liver. And so what we do before resecting the celiac axis is to embolize the celiac axis. So the radiologist puts a coil in the celiac axis and blocks it off, and that promotes collateralization. So you see, this is the gastroduodenal, superior pancreatic, and inferior pancreatic coming from the SMA. So once you occlude the celiac, blood from the SMA flows up to the liver, and so flow in the GDA is reversed. Now, if you do that 3-4 weeks before the operation, it makes it safer. And then you can just resect the celiac axis without needing to reconstruct. That's called an Appleby procedure. I think we've done about 3 of them at Oxford, but it's relatively rare. We've done all open, but they've been described laparoscopic and robotically. Any other questions?
Do you speak for them?
Sorry, there's the question of artery first Whipple's and Ram's distal pancreatectomy. So yes, both techniques are used. Ram's is more or less routinely used for distal pancreatectomy, both for laparoscopic and open. It's the standard technique used for adenocarcinomas of the distal pancreas. Laparoscopic, it's actually easier because you don't want to mobilize the spleen and tail of pancreas and get it to the midline. You want it to be lying down flat and start your approach at the neck of the pancreas. So Mohammed, you might have missed that, but I think I covered a bit of that initially with the lap distals. But yes, RAMS is very important tech concept, and also how to achieve it technically. So the part of RAMS that's difficult for laparoscopic surgery is actually the lymphadenectomy around the SMA, the left border of the SMA, and the hepatic artery and top of the celiac. And that's where robotic has an advantage over laparoscopic. The artery first Whipples, yes, so that's again an important thing. There's been a lot of sort of interest in the posterior artery first approach, which is what we've tended to do at Oxford. There's a more recent discussion about approaching the artery from anterior and whether that gives better clearance to all the tissue between the SMA and the uncinate. So just for people, just for everyone else who may not be familiar, in a Whipples, the uncinate goes behind the SMV here, and there's a lot of tissue behind the SMV that connects the pancreas to the SMV, and this is rich neurovascular tissue, and this is the most common site for R1 margins, and also the most common site for local recurrence. So whereas 20 years ago, people would stay flush with the pancreas because they were worried about the vessels, nowadays people will stay on the SMA to try and maximize clearance. But even with that approach, you still have a 60 to 80% R1 margin positive rate. So with the posterior approach, you get the entire small bowel up and the right colon and find the SMA from below, a bit like you do in organ retrieval, and then dissect the lower, the SMA from below. The anterior approach that has been described is to transect the pancreas and find the SMA from anteriorly, and then go down this plane. And the advantage of the anterior approach is you can go higher up all the way to the celiac and get a slightly better clearance of that tissue, which is nearly a bit like a mesentery. And it's supposed to be one of the advantages of robotic surgery, in that with robotic surgery, you more
Can't hear you, Mr. Soonawalla. Can't hear you. You're muted.
sorry. Yep. So
We missed you about robotic, advantage of robotic.
yeah. So, oh, sorry. How much did you miss? Did you pick up the DJ flexure being mobilized?
No.
No. Okay. So in robotic, in open surgery, you cockerize the duodenum and the head of the pancreas and expose the SMV, and then you go infracolic and mobilize that DJ flexure from the right side. In robotic surgery, you keep mobilizing the duodenum and keep pulling the DJ flexure out. So the entire DJ flexure comes onto the patient's right side. So you end up with the duodenum carrying on with the jejunum down here. So you more or less straighten that curve of the duodenum and the D3, D4, DJ flexure curve. And then you can imagine that the SMA has a mesentery with proximal jejunal branches and the inferior pancreaticoduodenal and all the nerve tissue. And you've made it in a single line rather than twisted. And you can then approach more easily from anterior, and you can even carry up all the way to the celiac trunk. So there's a suggestion that now it's possible that robotic surgery may even, with experience, give you better clearance rather than worse clearance. I think one of the challenges that you all will face is in training. How do you train for these complex procedures, particularly when for the next 5-10 years, the consultants will also be learning and training. And that's going to be a big challenge, I think, for all of us.